As cardiovascular medicine practitioners, naturally, we want to select the best anticoagulant for our patient with thrombotic problems. And for stroke prevention and atrial fibrillation, I think the first issue is, how do we assess stroke risk? Do we stick with the good old CHAD system that was used for all of these landmark clinical megatrials? Or do we move to the new era to use the CHAD's VASC scoring system? If we actually dissect out the CHAD's VASC scoring system, we'll find that it's more predictive and more accurate for determining and prognosticating stroke risk than CHAD's. And on the other hand, if we use it, that is the CHAD's VASC scoring system, ultimately we're going to have higher scores, and we're going to be placing more patients on anticoagulants. I think before these novel oral anticoagulants emerged as having less major or clinically relevant bleeding as a class of agents, that would have been problematic, because we certainly don't want to be increasing the bleeding risk for our patients. But now we've seen definitively, especially with ARISTOTLE, 1/3 reduction in major bleeding complications. I think we're now in a much safer zone to be assessing our patients in the office with CHAD's VASC in addition to CHAD's. We don't really need the CHAD's VASC score if the CHAD score is 2 or greater, because all those patients are going to be on anticoagulant. Where CHAD's VASC comes in handy is it will elevate some patients from CHAD 0 to CHAD's 1 or 2, and other patients from CHAD's 1, where there's a little bit of play. You can use aspirin, or you can use an anticoagulant. It will elevate some of the CHAD's 1 patients to a CHAD's VASC score of 2, and the guidelines from Europe in the ESC say patients with CHAD's VASC scores of 2 or greater should be anticoagulated. In other words, we're expanding the pie, or the group of patients with atrial fibrillation who should be anticoagulated. I believe that if we open up the door and allow more patients to be anticoagulated in this era where we have a menu of novel oral anticoagulants, that we might be able to look into the future when we do our post-marketing surveillance and actually find a reduction in stroke, because AF is the cause of stroke in 1 out of 5, 1 out of 6 patients overall. But as our population ages, when we get to octogenarians, it can cause up to 1 out of every 3 strokes. And wouldn't it be sweet to be back at the ESC meeting in 5 or 10 years and track and see a reduction in the rate of stroke over this time? We might hypothesize that such a reduction is due to the implementation of prescription of anticoagulants and these novel anticoagulants, coupled with better controls of risk factors for stroke, such as hypertension. And again, if this will sort of bring in some of the basic elements of care of our patients, like control of the blood pressure and control of the cholesterol level, along with the higher tech advantages of our designer drug novel oral anticoagulants, and synergistically we might find great dividends in the future.